I'll invite Dr. Gordon and Dr. Walker to return to the line and initiate our speaker reflection. Just one programming note that Dr. Gibson had to step away. So Dr. Gordon, may I turn to you to seek your reflections from yourself and from the colleagues who were on the gaps and barriers conversation?
Sure. Yeah, a few things occur to me. I mean, I think I have three sort of general observations. One is, I'm very struck by the lack of universalism in access to basic health coverage, but also universal access to a lot of the sort of upstream factors. So we end up with public programs that are residual and categorical, and then the public and private commitments to those are uneven. And this yields, what a number of speakers noted as a sort of lack of coordination, a lack of systematic approach, which is, painfully evident in our patchwork pandemic and the different ways in which different jurisdictions, different interests have responded. And then I think it's very clear that, we have substantial sort of equity deficits across this system in the way in which we define who is deserving and undeserving of care. We have equity deficits within the system based on patterns of bias and discrimination in the delivery of care. And we have equity deficits upstream and outside of this system, which feed into it. And it sort of makes me think, which would be my third point, about the way in which we often think of this in terms of phantom trade-offs between liberty and equity, or between equity and efficiency. Because the reality is, we have a system in which we don't have equity, that's well documented by our speakers today, in which we don't have efficiency in terms of what we spend and what our outcomes are. And we don't really have what you would define as liberty, unless you define liberty, unless you define healthcare narrowly as a commodity, and rather than a right of citizenship. So those would be my sort of reflections, and I'd ask Mr. Courtney to follow up.
We are not able to hear you, Mr. Courtney.
I apologize. That should work now. Again, I apologize, and thank you all. I would echo many of the items that were said. I think one thing that I'm leaving with is that lack of coordination, or that think that it is a zero-sum game, and that in that coordinating efforts, and then also just emphasizing the need for those local decision makers and those local communities to really be guiding some of those conversations around need and what those wraparound services truly look like. So the outcomes of one's life and one's health is not then determined by a zip code in some of the examples that were given. But those are some of the key things that I'm taking away with, and certainly have enjoyed the conversation and engaging with you all.
Mr. Asasi?
Can you guys hear me? Great. One of the things I really enjoyed about the conversation was this acknowledgement that we do have to really think carefully about the underlying incentives that folks are responding to, and that simply sort of pushing for a culture of health or equity because it's the right thing to do is insufficient. That we have to think about how we change the business of healthcare, how we change the financing of healthcare, we change the way that capital is created in healthcare, so that we can actually achieve the goals of a culture of health and really addressing health equity.
Thank you.
Thank you all. And Dr. Walker, I'll turn to you and for your colleagues who were also a part of the Priorities Moving Forward panel.
Thank you so much. And I think that what we have an opportunity to think about in the second portion of our conversation was how we move forward, whether it's thinking about framing the issues and concentrating on specific populations that are affected by structural racism, but also trying to figure out how to shift those ideologies. And we know from the conversation, there are models to do that. And I think what I was reminded is that there are multiple examples. Every speaker on our second panel talked about examples of where this has been impactful, and we can take those lessons into forward momentum, whether it's including community engagement, focusing on a few key priorities, as Dr. Gee mentioned in Louisiana, and I think Dr. Erickson, you also, sang true to the tune of saying there is money in the system, there is a business model, we can fund it, and we can fund this work around equity, but we have to figure out those lessons and gems to carry it forward for decision makers to really be able to tackle hard conversations and figure out the glide path to getting there. So I'll first go to Amanda to see if you have any comments or reflections.
Yeah, thank you so much. I think that what is just clear from all of the presentations is that we truly cannot achieve a culture of health without first achieving racial justice and racial equity. And what that really requires is a deliberate upstream focus on the systems and policies and structures that have set the rules of the game with disproportionate benefit to certain populations. And also that it really is requiring us to both look at the mental models and narratives that are influencing the way that we make decisions, and also that we need to ask ourselves very different questions about what is happening, for why, to whom, and how, to in order for us to address it appropriately. And then the last thing I'll say is, I think in all of the offerings today, it's clear that the most meaningful changes must engage one's fundamental sense of identity, humanity, and place in the world. And that's the deeper level at which you see protesters and movement leaders are pushing for all of us to struggle with. And as we find ways to more successfully, or hopefully successfully, recover and rebuild, it's imperative that we consider that curb cut effect and act accordingly. That the nation has to grasp the lesson of this moment. It is the most vulnerable. If they do not thrive, the nation will not, and our destinies are intertwined. And so therefore that is the curb cut effect. Thank you.
Thank you. Dr. Gee?
Thank you. So, definitely that change is possible, absolutely, but you have to focus on clear outcomes and data-driven goals, and you have to create structures to improve things. You can't just assume or hope for improvement. You have to have staff, you have to have funds, you have to have a vision, and that positive vision creates change. It's explaining to people how they can be a part of ensuring that no woman dies a preventable death. That is enough. It doesn't create, you don't need to stick, the carrot of doing better is enough. And so want people to leave with hope that this is a very difficult moment in our country, but Louisiana, one of the states with some of the worst history in terms of racial inequity, continues to have Angola Prison, the largest landmass prison in this nation, that we were able to be the first state to have hepatitis C drugs for our prisoners. And that was informed as well by our Secretary of Corrections, who is committed to achieving optimal health. So change is possible. Now, don't get discouraged. There's a lot of work that needs to be done, but if we all start in the corners where we are, if we honor the fact that we don't always know the answers, if we can have humility and honest discussions with each other, if we can recognize the past, then we're going to have a brighter future and make the change that is needed for our country and for our health systems.
Dr. Erickson.
Well, it's nice that there's another person who's trained in history on this panel or in this webinar. One thing that I find, historians kind of bristle at is this idea that it was the agricultural South versus the industrial North in the Civil War. And reality was that both sides were agricultural. I mean, the North did have more factories, but by and large, you know, nobody lived in cities in the 1860s. Like this all starts in the 1880s that we're just, and I feel like to some degree we're learning how to take care of each other, you know, in a way that's new, and we're toddlers at it, and we're terrible, and we stumble, and we're awkward, but we're getting stronger. And I just say, one example of this is I'm the most junior person in a pretty senior call at the Federal Reserve Bank of New York. It's March, markets around the world are seizing up. It's a very scary time. You know, all of us experienced grocery store shelves being emptied and whatnot, but it was very scary in New York. There was a refrigerator truck next to my house, and where their bodies were being stored because the morgue was overfilling. I mean, it was just sirens all the time, and there was a lot of fear. And yet the discussions on that call were, we have to be careful that we are not recreating the redlining maps of the 1930s, that our pandemic relief efforts are not increasing inequality, that they're reducing it. And we have been scrambling to try to figure that out. I'm not saying we've succeeded at doing that, but the idea that we now know that's part of our thinking, the curb cut effect is part of our thinking all the time in many, many different realms, I think is part of the process that's getting us from toddlerhood to adolescence to hopefully adulthood, where we finally get to the point where we take care of each other in a fair and equitable way.
Great, thank you all for those additional reflections. So I'll go ahead and turn to the question and answer box that folks have been submitting questions through and pose them to each of our panelists. Mr. Sassi, this one I believe is directed to you based on the presentation you made. Can you comment more specifically on what changed in the US over the past 25 years that contributed to deterioration in women's health outcomes?
Oh, that's a terrific question. And there's a lot of different reasons that literature cites to account for that. And to be clear, it's not that overall health of women has deteriorated, it's that in comparison to the other well-resourced nations that have systems of healthcare, our women are doing worse. So it's really about us falling behind as opposed to falling behind the advancements of other countries. But I would posit that you know, there's no question that the social inequities in our country writ large, across economy, the ability of upward mobility, all those things have a very direct impact on health outcomes. And so it's a very, very large answer to the question. It's a really deep question. But I also would say, and so really the culture of health and the idea of addressing social determinants is probably the #1 strategy to address the reasons why we're falling behind these other countries. But I would also say that, as my presentation tried to illuminate, the way we pay for care and the fact that we have fee-for-service healthcare is probably the single largest culprit, other than income inequality. Meaning, these other countries have all have systems of healthcare that have strong government oversight and much greater integration between social services and healthcare. And so the fact that we have this very fragmented system that's reimbursed through fee-for-service, and at the end of the day, what that means is providers are not held accountable for the outcomes of their patients long-term. They're just held accountable for this one procedure, this one moment of care. Those are the two probably most significant factors that result in the fact that our women in this country are dying at a younger age than in these other industrialized nations.
Thank you, Mr. Sassi. I'll ask if either Dr. Gee or Dr. Walker would like to comment, given the roles that you all have been in as policymakers.
I'd like to add to what Frederick just said. I think it's really probably more important that as a factor that women do not have equal pay, in fact have, particularly Black women, even less equal pay, almost 40 cents on the dollar less here in Louisiana, 30 cents on the dollar less for white women, that we do not have adequate child care. We do not even have leave guaranteed after a birth of a child, and that these systematic policies put women at a deficit. And as a practicing gynecologist, I can tell you that COVID has just been a stress test for all of the social inequities, that women are dying of alcohol overuse, they are depressed, they are in stress, they are expected to be teachers and caregivers for parents and caregivers for children, and yet not have equal pay and not have an appreciation for their caregiving roles. And so women in this country have inordinate amounts of stress compared to countries where women have proper social supports and where their roles as caregivers are more valued.
Great, thank you, Dr. Gee. Would any of our other speakers like to comment on this question? Next question in the queue is to you, Dr. Erickson. What kinds of health equity-oriented policies enable such community development projects as the ones that you've shown in your slides, so that it isn't always cobbling together resources from many partners who have to navigate complicated tax credits and funding?
Yeah, part of the problem is that these are all super complicated. Like that project, like that first project I mentioned, the Conway Center, probably had 11 sources of financing. And so, you know, it is too complicated. I am drawn to this idea of places where the medical care cost risk is concentrated in one entity. So I'm really curious about, like, let's say a county with one health insurer in a rural place perhaps, or a company town, or I do think there would be an opportunity to sort of create these sort of islands of population health business model in a fee-for-service C that would really show the country how you could sort of simplify some of the ways of financing, capture the benefits more effectively, and create a more simplified sort of investment in kids that result in savings long-term that get reinvested in the next generation of kids. Like, I think you could demonstrate it in some places, but at the moment, it's just very hard to make that work. And often I think about, like, I live in New York City, and I think, you know, if we could prove it someplace, if we could prove it in Maui and a rural county in Arkansas and a company town in Ohio, and really, it was really well understood, then maybe we could, you know, think about an upstream intervention fund that each entity that owned the downstream risk contributed to the percentage of their risk into that fund. So if I'm I'm Acme Health Insurer and I have 20% of the risk in New York City, I could contribute 20% that made sure, and my other holders of those risks would also contribute to it. Then the intervention fund would make sure that all children arrive at kindergarten ready to learn. Like, that would be a way which I think we could start to simplify it. I think we could take some of the complexity out, but as it is now, it's a Frankenstein's monster, and it really requires a lot of knitting together of different programs, and it's not sustainable in the long run. But I think once we get some of these insights, we'll be able to rebuild.
Yeah, I'd like to add to this part of the dialogue, because as Secretary of Health for a small state, we were working really hard on this very concept. I had Medicaid and human services programs under the same umbrella, and those touch points are incredible, but there also is not necessarily flexibility to easily navigate. And so you're always constantly trying to figure out how to braid and blend funding, which is a nice way to express the Frankenstein model, which I think the funding for many of these projects comes from Medicaid in terms of what they can pay outside of the healthcare walls. It comes from community benefits dollars in certain places, in certain states that hospitals already are committed to. It can come from philanthropic sources, obviously, the private sector. We created a model called Healthy Communities Delaware, which is intended to do collective impact funding, to potentially resource social impact bonds and other investment strategies that come together. But every project is different. I think there needs to be greater state flexibility. There needs to be almost a wellness fund or trust that's established at the federal level that can provide some seed money to invest in these new models. And then we obviously need to move to value-based payment models that incentivize the healthcare system to streamline how we're approaching social determinants of health. But I think it's a big step in the right direction to start with data-driven approaches and get to models that are examples and bright beacons for where we need to go.
Thank you. A question posed to the full group, so we may need a moment to reflect, but I would appreciate a response from each of our speakers. The question is, if we understand and accept all of the facts presented, and we know that a multi-pronged response or initiative is needed, where do we each put our time and efforts to address the issues of advancing health equity in systems and policies? Does that differ by discipline or job? Does it differ by entity in terms of government, education, research, the private sector, healthcare, labor, etc.? So I think this question boils down to, we know that there's not an unlimited amount of time and resource. It's also not a zero-sum game, but how and where can we put forward our resources, time and efforts to address these issues through policies and systems?
I'll just start to say I agree with what Cara said. I think if COVID has taught us anything, just in the previous point, we've got to have either a public health trust fund or a social services trust fund or some way to be able to use dollars for things that actually buy health, because we've maximized the function of buying sick care. It's not working, and until we're able to really make the investments that are needed, we're going to be at a deficit position. What I would say is on change is focus on the levers and the tools that you have at your disposal. You know, one of the reasons I didn't focus on obesity when I was health secretary is because the food here is so darn good. You know, there was no way I was going to get people to eat less gumbo, so I didn't try. You know, I focused on infectious diseases. I focused on maternal mortality. I focused on things where there was clear evidence that an intervention would make a difference. So I would say data-driven, look at your levers, have a clear set of goals, measure them, and define your success by them, but focus on what you can change.
Yeah, I would echo that. I think that we really have to start where we're at. For some of us, it means where we live, work, play, pray, you know, think about those local influences and our own personal networks, where it can start with just our own responsibility at work or at home. We also need to engage in the political process, and that does not necessarily mean running for office, although it can for some people, but it could just mean being involved in the political process, voting, making sure others around you are registered to vote, and making sure we're educating our patients and our families about what the opportunities are. And I think that from that will stem other opportunities around equal access to jobs and making sure that we are responsible as corporate citizens, making sure that there's wage equity, and we're looking at our data internally around jobs and advancement, but also beyond in terms of health outcomes and the data that we have access to. So start where we are, start with the programs that are in place. I think there is a huge opportunity to invest in structures and programs that could be additionally resourced, like earned income tax credit, like what we're doing around income supports in TANF and SNAP benefits, even as soon as today, really just working with the political process to make sure that we have investments that make a difference to get through COVID-19, but also sustain us beyond.
Thank you. I'll move to any other speakers that would like to respond to this question. Perhaps Dr. Navarro?
Yeah, thank you, Avery. Yes, just to add on, I mean, completely agree with Dr. Gee that really the place to start is with the data and looking at disaggregating data. Also being clear about what is your result and who is the population that you're serving and will be focusing your efforts on. And, you know, just to be really honest, the work that we've all been talking about, it's not the big, flashy, sexy work. This is the grunt day-to-day, behind closed doors work that we do, and it really is requiring of us to ask ourselves the questions that I shared at the very top of my presentation. and asking each other those questions. Who's going to benefit from this? Who will be harmed? Who's missing? I think in this time, especially in times of disaster, local leaders often forego community voices and engagement for sake of expediency. And we've already seen a lot of our partners say to us, you know, we messed up. We were wanting to run too fast and try to kind of fix and quell the fire. And now we have so many people and more that we've perpetuated leaving behind because we didn't include a racial equity lens first and foremost. So the need to really pace yourself. There is a time of urgency, but it's also even more important to get it right. And that does take time, and it does require centering the voices and the wisdom of communities most impacted as part and leading the solution.
Thank you, Dr. Navarro. Mr. Courtney?
Yeah, I'll jump in. I think for us as American Indian and Alaskan Native tribal communities, we're a little bit in a unique position given our relationship with the federal government, given our relationship with state governments. While I completely agree with what has been previously said, I think that we have some catching up to do in regards to creating that data and having access to that data. And therefore, I think a large part of policy folks like myself, a big need is just continuing to educate decision makers that are unaware of the structures that be within that run and help provide funding to our health systems. I also think, you know, things like the Indian Self-Determination and Education Assistance Act allows tribes to run their own health facilities and also allows tribes to combine different types of federal funding to really have tribally driven and local programs. And I think that when we have seen that, things like the Special Diabetes Program for Indians has shown for the first time lowering rates of diabetes. And I think it's just ensuring that non-native decision makers are comfortable with and are kept in the loop, and just being able to showcase the successes that we have had when we do have the ability to make those decisions on our own. And I think on the surface level, when you're not educated about tribal communities, you may think, why would we have doctor visits during a powwow? Or why would we do diabetes services during a certain cultural event or a basketball tournament? As a teacher, one of the best places to engage with parents was at basketball tournaments. So we want to have parent-teacher conferences, and we need to meet those communities where they are and really respect and acknowledge the wisdom that those communities have at the local level.
Thank you, Mr. Courtney. I'll leave the floor open if any of our other speakers would like to respond.
One idea. I just think this is such a critical question. Like, what do I do tomorrow? Like, it's just so overwhelming, and it's something that, you know, I've been working in community development for 30 years now, and we just believe, we had this theory of change, which was, let's just sprinkle as many amenities as we possibly can in a low-income community, and maybe that'll just kind of tip it into sort of thriving. You know, that would work, and that just didn't work. And I think a lot of other fields, you know, came to the same conclusion. You know, those in health often thought that if you had access to health care, medical care, that was going to be, that was the holy grail, you know, and that many people were closer to that. Now we're not as where we need to be, but that didn't work either. I mean, even places like Britain, where you've got the Black Report and other analysis that shows that even with universal access to very high quality healthcare, that does not reduce that doesn't advance health equity necessarily. And so lots of us, just because we didn't know what to do, the trick is that it all has to work together, you know, and we don't know how to do that yet, which is why I think creating a market is the only thing I can really think of, because it's so complex, and markets have the ability to kind of incorporate data in a way that's dynamic and can coordinate actors across different sort of domains. And you know, when I was pitching the book to Brookings, they said, well, what's the Hollywood pitch, right? There's a, you know, these two titles that smash up, you know, Weekend at Bernie's meets Psycho or whatever, you know, and mine was, my pitch was Catcher in the Rye meets blockchain, you know, and blockchain technology, you know, and I thought, you know, maybe no one reads Catcher in the Rye anymore, but, you know, in that book, Salinger is writing about Holden Caulfield is the main character, and he thinks everybody's a phony, and he has this recurring dream where he just wants to be the guy that catches the children who are running towards the cliff, and they can't see the cliff because they're too short, and he catches them. You know, he's the catcher in the rye. And if you could find a way to create the solutions that are smarter, some built into the neighborhood, the guardrails, and some that are activated when they are needed, the airbags, and find a way to pay for that, which is generally, I think, by avoiding some of the downstream consequences of not doing that to start, but I think there are other sources as well. And if you could sort of coordinate it using some technology like blockchain, an open ledger, totally anonymous, totally private sort of a way where you can coordinate these interventions over the life course. I mean, I think we need that kind of a breakthrough in order to get to the point where we all can figure out how do I do my thing and step back and let somebody else do their thing to make sure that that kid gets into adulthood with the skills they need to thrive.
I wanted to say one other thing that was a powerful discussion I had early on during COVID. A Fortune 500 CEO called me and said, should I give to Black Lives Matter? And I said, well, that's okay. I said, but before you do that, how about you look at your family leave policies? What's going on at your organization? How about you look at sick leave? Have you provided folks with PPE? What about pay equity? Who's sitting around your board table? Does it look like America? You know, and before laying anyone off, have you looked at your own salary? And maybe cut that before you let someone go, you know, when their family needs the income. And after you do all of that, maybe give to Black Lives Matter. But how about doing structural systematic things first? And I do think all of our organizations, whether it's our universities, academic health centers, the businesses we work in, we can all do a little looking under the sheets, looking at everybody, you know, who's sitting in a room with us wondering who's missing, and having a much more active role in our daily lives. And in terms of thinking about those systems and how we personally can change them.
Thank you, Dr. Gee. Dr. Gordon's questions posed to you. Given the extensive research that you've done on policy creation, decision-making here in the United States, if we know that culture dictates how policy is adopted and applied, how do we change hearts and minds to accept the data available and apply it in a way that will achieve health equity? So how do we create that movement of data into policy, but we know that culture is going to dictate how policy is actually being applied in the field? You're on mute still.
That's the refrain of 2020, you're on mute. I mean, I'm not sure that history and culture dictate in that way. I mean, I don't think by any means that we're imprisoned by that history, and I think we're creeping towards a fuller awareness of the way in which the fundamental equity failures in policies surrounding housing, surrounding economic development, surrounding urban renewal, surrounding mass incarceration, and then the sort of policy feedbacks on civic engagement and the like. I think the better we come to a realization that these are that these historical forces are policy driven and not simply market outcomes. They're not as a result of the behavior of disadvantaged populations and that sort of pathological explanation that we were attached to for so long. The more likely it is that we're able to sustain policy and political solutions. That if the damage is political, then the political solutions become, or the acceptance of affirmative political solutions is firmer and more legitimate in that respect.
Great, thank you, Dr. Gordon. Would any other speakers like to reply to this question?
This is Frederick. Just really love this vibrant discussion about the power of data on all of this. I think that this is, to me, one of the things we need in this movement is disruptors. And I think that disruptors being, these missing ingredients that can allow for real watershed moments in understanding and in the collective will for action. And I think that we've been struggling for decades in this country around the availability and utilization of data, in particular healthcare data, and data that's connected to other sources like social services and corrections, et cetera. And there's no, the fundamental, we've done a lot of research about why it is that these data are not available. And fundamentally, it is not the healthcare data in particular, it's not in the business interests of hospitals and payers to share these data. And so I think that, but the other side of that equation is that if you stop just about any person walked down the street and said to them, who owns your data, your healthcare data, your medical record, your tests, right? They all believe and are right that they own those data. And so there's quite a moment there for us as a country to finally settle this question, which is that healthcare data should be available ubiquitously and interoperable, ubiquitously. When that happens, and it truly is available to policymakers and researchers to understand the waste and the dollars that are being spent. I mean, $3.6 trillion is a very large figure to wrap one's mind around. But it will truly transform, I think, the business of healthcare and our understanding of the connections between poverty and race and income inequality and the health of our people. And so if there was one thing, and there's so many things I would do if I had a magic wand, but one of the things I think that could be most powerful is this idea of creating rich data sources that allow for analysis and action on the part of policymakers.
Thank you, Mr. Sassy. Amanda, did you, or Dr.?
Yeah, I'd like to build off of the last couple comments. I think the idea of changing hearts and minds is really a sticky one, and it is personal. And I think that is where the deeper work must happen. I mean, when we talk about policy and politics, the domains seem abstract, but it's comprised of people, of human beings with their own worldviews, with their own experiences and perspectives and interests and racial biases. And, just one example, I mean, we're still struggling with trying to get over the race exploiting trick of divide and conquer. And that's what defined the Southern strategy. President Lyndon Johnson at one point said, if you can convince the lowest white man he's better than the best black man, he won't notice you're picking his pocket. And so, that is something that's so deeply entrenched in our conversations, in our messaging. I mean, we're beyond now dog whistling. I mean, it's now just blatant, racist, xenophobic, divisive narratives that we have to start countering. So the best that we all as a community and as a sector can align our narratives and our messaging in a way that begins to counter and disrupt these narratives is going to be the critical work that goes along with the policy change. But we can't ignore the narratives and the messages that are underneath the decisions that are being made on a daily basis.
Thank you, Dr. Navarro.
If I may just add very quickly, based on the comment that Dr. Navarro and Director Azali said, I think in regards to disruptors, I just want to give a shout out and acknowledge, for the first time ever in American history, 2 Native women were elected to Congress. And when we're talking about changing those hearts and changing those minds of decision makers, that has been one of the biggest successes and levers of change that now we have, again, for the first time ever, Indigenous women in the body that is making those decisions. So just want to give some background on the power of education and the power of changing those minds.
Thank you, Mr. Courtney. That was actually one of our other questions to ask, was kind of who are the spokespeople that can lead and or influence decision makers towards taking steps. And I think it is very important to acknowledge that it is the first time in history that we do have a Native American or Indigenous women being represented in Congress. Dr. Gee, there's a question directed to you from your presentation. Can you describe how the disparity ratio is measured and why it did not change when morbidity from HTN and hemorrhage did decrease?
Yeah, so the ratio looks at the delta between white and Black women and what their outcomes are. And because we improved outcomes for all and we improved them rapidly and at the same time, outcomes for both Black and white women improved. As I mentioned, 60% drop in overall morbidity, 39% drop in hemorrhage, but it was uniform. And in other words, the Black women's outcomes did not improve more than the white women's outcomes, so we did not decrease the delta. All boats rose. And so the question, our focus on racial equity, our focus on looking definitively at data, having our institutions be reflective of their policies, looking at the environments they're creating, being patient-centered, all of that is important and happening along with this work, but it takes time. And so that would be my theory as to why we haven't seen Black women improve more than white women, is that the changes that have been made in large part have affected everybody, the quality of care for everyone. Everyone gets a hemorrhage card, everyone gets a checklist. So that's positive, but it's not enough.
Thank you. We do have another fairly general question. How do we balance getting emergency crisis services to our underserved populations right now while still trying to focus our efforts on the upstream determinants of health? So perhaps Dr. Walker and Dr. Gee, this might be a good question to pose to you all, but I certainly welcome perspectives from some of our other panelists also.
Absolutely. Coming out of the COVID-19 crisis has definitely shown us that there is a need to invest in the immediate term to make sure that we're not extending those health inequities. So the work that was done around unemployment access, around housing resources and rent stabilization, mortgage eviction policies that were built into many, many stay-at-home orders and executive orders across the nation were critically important to make sure that we weren't creating worse outcomes as we went forward, but they still missed people. And I think that is the challenge. We still had to set up a separate fund for those who were ineligible or did not receive federal assistance, and local dollars were pooled in our state of Delaware to make sure that we could deliver food to seniors who were stuck at home and make sure that they had prescriptions so that they didn't leave their house just to get needed supplies. And that was all through kind of a local level support and initiatives, through very creative workarounds. I know our system was trying to figure out how to make sure children were getting immunizations. We're still behind and where we'd like to be, but just setting up tents so that children could do a drive-through visit. I think that is what we need to continue to do. And what we'll see in that emergency response is a stabilization, hopefully through this fall, that will allow us to take those best practices and extend them further. And I think we're seeing that around telehealth and technology and what we're doing around remote work and keeping people engaged and engaged with their benefits in non-traditional ways that are truly innovative. And I think will continue forward for the next year or more, depending on how we see things. But I think we have to find those lessons learned and find that there are new ways of doing things.
Well, there's likely no state that's experienced more crises due to climate and weather than the state of Louisiana. And just this summer, 6 times have been in the cone of uncertainty and been hit with one of the most massive hurricanes ever to be recorded. The Secretary of Health I led both preparedness and response for health. And one of the things that Frederick so well noted is that we don't have good data. And what was clear to me is that the same people who are vulnerable for not being able to evacuate from a storm are the people that have uncontrolled hypertension, are the people that have untreated mental illness, and that we ought to have a social index that we go to first instead of what we do now, where EMS knocks on every door, hoping to find people. Why don't we go there first ahead of the storm and evacuate in a way that's deliberate and based on our data? And it's simply because the priority has not been there. We need a way to identify, whether it's through an NPI number for every person in this country or some way, in a safe way that respects individual autonomy and privacy, to have a way to link all these data systems so that we can better address disasters. We're not where we need to be. In Baton Rouge, when we had 100,000 buildings underwater, floods in the governor's mansion, and thousands of people in shelters, I felt like I was in a developing world where I had worked as a medical student. You know, people coming with their own pharmacy cash from their doctor's office, spreading it out, trying to get people what they need. And here was a CVS and a Walmart within 10 miles. You know, so we changed it, but my point is that we can do better, and it's because we're not prepared and we're not thoughtful about risk and how to address it, and we're not thinking ahead of time in ways that are coordinated and result in better outcomes.
Thank you, Dr. Gee. I wonder if any of our other panelists would like to speak to finding that balance between responding to downstream crises such as COVID-19, while also knowing that we do need to look further upstream and improving those upstream determinants of health. So Dr. Navarro or Dr. Erickson or even Mr. Courtney or Dr. Gordon, any thoughts on how we really look at those upstream impacts in our policies, choices, and decisions?
You know, I think there's an opportunity here, and this isn't quite so focused on the response to COVID-19, but when I made this presentation before, someone accused me of saying, well, what you're talking about, if you want to try to use, you know, the $1 trillion a year that's spent on chronic disease, that's really the byproduct of living in poverty, on the upstream determinants of health, what you're really arguing is defund the medical system, you know, and I thought, well, that's really an interesting way to put it, and there has to be kind of a transition to, if you're going to sort of do both simultaneously, work upstream and respond to the crisis in front of you, we're going to need different ways and models to do that. And one way I think that we could consider doing that is to think about using private resources to pay for the upstream. So here I'm thinking about the social impact bond. The Goldman Sachs has tried this a couple times. One was on recidivism in New York City for people in the juvenile justice system. Another one was in Salt Lake County, focusing on providing childhood enrichment to kids who were showing up at school not ready to learn. What that experience taught us, I think, is that, you know, you can use some data. You can basically you have to sort of they used outside dollars, so these were private sector funds to sort of enhance case management in the case of the juvenile delinquent example, and these early childhood enrichment experiences in the Salt Lake County example. And the idea was that if you could hit some threshold, fewer people returning to prison in the one case, and more kids arriving ready to learn in the second case, then you would trigger a payoff. You know, and in the case, it was the criminal justice system that was going to be able to do that in the first example, and the school district was going to be able to do it in the second example. They didn't hit the numbers. They weren't able, the intervention didn't work on recidivism, and Goldman Sachs lost a lot of money on that. And it did work with the Ready to Learn at kindergarten in the Salt Lake example, and they were paid back. But you'd be surprised, Goldman Sachs does not like to lose money, and they're not doing that anymore. But I just thought that was sort of a really creative example of sort of, there's got to be ways I think we can use outside private funds to focus on the upstream, while we're still sort of using public dollars to deal with the downstream crises that are sort of presenting themselves.
To say, for COVID too, we need to go where the data shows us that people need help the most, instead of what happened in this country where testing was willy-nilly, wherever people would start. We should have had would want to do it. We should have had a national strategy going to zip codes first. And we know that Black families lost disproportionately numbers of loved ones. Black communities should have been the first places we were testing. Black communities should be the ones we're talking to when we're looking at vaccine trust and considerations and looking at enrollment into clinical trials. We've got to focus on people who need resources the most, and there is not a coordinated approach to do that. And during the ventilator shortage times, when we in one of our hospitals were 2 vents away from running out, it was an eBay-like environment at the federal level where states bidding against states, against the federal government. It was relationship-based, not need-based. And that really is unacceptable, and that's we should learn from and change and use data to drive needed resources in times which are unprecedented like now, where every state in the nation needs them. We can be much more deliberate about how we do that.
Thank you all for those additional reflections. Any other insights that folks would like to offer before we move to the next question? We do have a question about messaging. It was specifically to Mr. Asasi, but it is around language use and messaging. And we've got a couple of questions also about the terms and terminology that we use when we talk about health equity, particularly in the realm of the question says the history of racialized medicine. Is there a way to be more impactful on systems change rather than on implicit bias training? So I believe this person is asking, are there shifts in terminology that we need to consider when trying to make the case for decision makers, both in public policy and in private institutions, when we talk about advancing policies or systems change to advance health equity? So are there thoughts from you all on reframing of terminology or best ways to message to decision makers to elevate, to increase policies that would advance health equity?
One thing I learned from the lead of our Office of Health Equity is he framed the issue in terms of the other, which I thought was very powerful, as if to say, and I think we can all have empathy with this, look, someone in a wheelchair, if I've never been in one, I don't understand them. They're other, they're unlike me. Someone who has a different color skin, they're other. A male, is not like me as a female. What are ways that people are different that might make my ability to make a decision on their behalf, not as effective as if I look like that person? And so I think just having humility and thinking about othering for all of us and having patience, tolerance, and being able to tolerate when someone makes a mistake, that if they're trying, that we can, that's a teachable moment. I think all of that's really important, but having vulnerability and being able to describe, what equity is it's everyone achieving optimal health. And for that, we have to understand where our blind spots are as leaders and as decision makers.
Thank you, Dr. Key.
I'd also like to add that I think the messaging is very important, and coming from a framing that is seen as positive will gather more allies than coming from a place of a deficit. I think one of the messages that rang true earlier in our conversation with Frederick Asasi's conversation was that all of us should have the opportunity to live a healthy life and receive high quality healthcare regardless of our race, ethnicity in general. And I think that's the concept that we need to come from. That's the concept we need to approach with policymakers. They want to hear optimism. They want to hear what they can do, what is actionable, what is not a huge lift, what will bring along support. And so I know that that's part of the idea between putting out additional data to communities to let them know where we are, to bring them along, but also know where we have opportunities to create change and to create messaging that others can get behind. So I think the wording and the message is critically important as we move this work forward.
I would add, so 22 years ago when Angela Glover Blackwell started Policy Link and talked about equity and used the term equity, that was not a common term. And she got a lot of resistance and had a lot of people turn their backs on her because of it. And now equity is pretty much a household term. And we are now in danger of having it get watered down. And if one thing I've learned from her, it's if you don't name it, it won't get addressed and it won't get measured. And so this is the moment, and we are in a moment where we cannot ignore and not name what has kept us from achieving that vision that Dr. Walker just shared, and from Frederick. So I do think that we have to be more courageous and create spaces where we begin to talk about white supremacy culture, where we begin to talk about structural racism, where we begin to talk about why did these things thwart us from really achieving what we truly want for everyone. And I do agree, I do believe that we all have the same vision. And I think that there are things that are in our system that we've got to tear down brick by brick. And we've got to rebuild, but we've got to rebuild from a place of honesty and transparency and accountability. And yes, humility, being able to really come to this and say, I may not have all the answers. I don't know how to go about this conversation, but we need to start having them together.
Thank you, Dr. Navarro. And what a great point to end on. So I would like to thank you all again for joining us today as speakers for the session, offering your reflections and joining us for the Q&A. Before we close out, I do want to invite the President of the National Academy of Medicine, Victor Zhao, to offer some additional closing remarks. Victor? I think you're still muted, Victor.
Thank you. Ivory, let me first thank you for putting together an outstanding meeting. I was able to join from about 12:30 onwards, and I've heard all the great discussions. In fact, I texted Rebecca Gee a note to say, great job. So this is so exciting to me. You know, it is a difficult time, moment for our nation, but I think it's also an encouraging time because we're now ready to confront the issues. For a long time, we were looking at healthcare, what's the best way to care for people. We then graduate to think about health. Then finally we discover social determinants. But now we realize much of the issues, the root cause is structural racism. And that being willing and courageous enough, as one of the panelists said, to talk about this is really important and to confront it. And I do think that if I see what's going on in the nation, more and more people are ready to confront this. And so it may be difficult, but unless you're willing to address it and acknowledge it, it's never going to change. So thank you, all of you, for those lessons. Ivory asked me to reflect on gaps, barriers, and challenges as a decision maker, quote, and what are my priorities? I would say, Ivory, decision maker, maybe, sometimes. Decision influencer, yes. And certainly serving the institution, the public, the nation, globally, always. That's what I do, and that's what our organization should do. So yes, we are very fortunate, National Academy of Medicine, to have access to their best minds, to have resources, and to have, in fact, connections to decision makers. And since over the years, we have proven to be a trusted advisor, we have certainly exerted some of our influence. We're an organization that's science-based, curator of science, but also embodiment of science. And so what we always must do is to use evidence to bring forward the correct recommendation for the nation. in my mind, number one is to have value. What do we stand for? And what do we really want to do and hope to achieve? What's our mission? My own feeling is that once we understand this, and I think the National Academy certainly have put in health equity in its mission statement a number of years ago, but I would say the last few years have been an enormous learning lesson for all of us. The Academy is getting more mature and more purposeful. From looking at broad issues of health, which we still do, but to focus on addressing root cause. Ivy will tell you that in the Culture of Health program, we've been working very hard towards this with her leadership. And as we begin to confront issue of structural racism, health inequity, racial inequity, the events that happened this past 6 months have awakened us even more. After George Floyd and the many other, shall we say, tragic circumstance, I have told Ivory and the staff that we're taking this very seriously. We will change our own culture, but importantly, we're going to use the platform of our academy to not only talk about social determinants of health or equity, but really in every possible way using evidence-based to address structural racism. And the Culture of Health is not its renewal or possible renewal, but we're pretty confident it will be renewed in the next 4 years. Our studies will focus mainly on those issues. What can we do? How do we provide evidence for this? How do we actually confront this issue and make recommendations? So I want to give an example of a recent study we released just 2 weeks ago, or 10 days ago. Many of you saw the equitable vaccine allocation framework that we released. There, front and central is the issue of equity, social vulnerability, and therefore addressing the fundamental issues that we face. When we talk about the issues of vaccine, and to assure the public that a proper, well thought out, strategic, transparent allocation scheme will be developed. We're the independent organization that will do it for CDC, NIH, and the government. Importantly, we put high on our priority the issue of equity and came to the conclusion that the most important thing is to be able to look at those socially vulnerable population. We use the Cdc Vulnerability Index as a means to look at those who, in fact, are more at risk, if you will. And if you look at those issues, age, comorbidities, and living in crowded conditions, doing frontline jobs that nobody else can do, and all those risks, we recognize that many of these issues are also rooted in structural racism. So you can see how committed I am and our organization towards addressing this issue. And we're so fortunate to have all of you working with us, advising us, helping us do the right thing, and have Michael McGinnis, Ivory Clark, and their team to lead us in this direction. So thank you very much for spending the day with us. And I think this has been an enormously productive day. I've learned a lot, and we look forward to working with all of you. Thank you.
Thank you again, Victor, for those warm closing remarks. I just want to again echo the thanks from the National Academy of Medicine's Culture of Health program, our staff team, our advisors, for all of you that have been speakers at the meeting, as well as for all of you who have been participants. We truly value the insights and guidance and reflections that you have shared with us today, and look forward to taking that into future learnings with the program and with the academies. I'm going to ask that Julie put up our final poll everywhere of the day. We would like to hear from you all about what is the greatest opportunity to advance health equity within your sector. We'll leave this poll up until 3:30, which will be the conclusion of the webinar. And we again thank you very much for the time that you've spent with us today, and we look forward to future opportunities to engage you all. So have a wonderful afternoon, and we will talk to you in the short coming future.